Hello, hello. Okay. Right. Okay. Yes. So a very good evening, everyone. Yes. Am I audible now? Yes. I hope I'm audible now. Right. Great. So a very good evening, everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular two sessions, that is today and as well as tomorrow, I'll be doing the quick revision of the entire general medicine. And these two sessions will be useful for both the group of students, that is the students who are appearing for the NEET PG and as well as the students who are appearing for the FMGE also. These two sessions will be definitely useful and this will be more than enough. And what is that I'll be covering in this particular sessions is I'll be covering the previous year questions and I'll also be covering the quick revision of the individual topics, and I will also be covering the image-based questions related to the individual topic. So this is what I'll be discussing in these two sessions. Now, coming on to the today's session. So in the today's session, the topics which I'm about to discuss are the endocrinology is one important topic which I'll be discussing, right? Then followed by that, I will be discussing the connective tissue disorders. Then followed by that, I'll be discussing the nephrology, right? And then I'll be discussing the cardiology. So these are the four topics which I'll be discussing today. The session will be around 4 to 5 hours. And the PDF or the PPT of these particular sessions, already I have shared on my Telegram channel, right? My Telegram channel is, that is Medicine Made Easy by Dr. Rajesh Gubba. So in this particular Telegram channel, I have already shared the PPTs or the PDFs of the today's session. So you can join onto my Telegram channel and get the PDFs or PPTs from that particular channel. All right. Now, having said that, let us start with the today's session. So coming on to the discussion of the endocrinology, the topics which I'll be covering is the pituitary disorders, the adrenal disorders, multiple endocrine neoplasia syndromes, parathyroid disorders, thyroid disorders, and diabetes mellitus. So these are all the topics which I'll be discussing. And all the topics I'll be discussing in the form of the question, that is a multiple choice question followed by the discussion. Okay. Right. Coming on to the first question. Right. So this is the first question. We have a 28-year-old male presents to the emergency department with complaints of the excessive thirst and frequent urination. He reports drinking large volumes of water and still feeling dehydrated. On physical examination, his mucous membrane appears dry and he is mildly tachycardic. Laboratory investigation reveal low urine specific gravity, high serum sodium. Which of the following hypothalamic nucleus is responsible for the secretion of the hormone affected in this patient's condition? I'll just give you exactly 1 minute. Supraoptic nucleus, paraventricular nucleus, median preoptic nucleus, arcuate nucleus. Right, very good. So we have the answer. Okay, first of all, what exactly is the clinical scenario suggestive of? So the patient is having the excessive thirst and as well as the frequent urination. Right. So this clinical picture, it is suggestive of diabetes insipidus. Why? Why? Because along with polyuria and as well as polydipsia, if you take the investigations, there is low urine specific gravity. That is what you will observe in case of diabetes insipidus. And in diabetes insipidus, you will have hypernatremia. So the clinical picture is suggestive of diabetes insipidus, in which the hormone which is being deficient is the antidiuretic hormone. Now, where exactly is this antidiuretic hormone being produced? Please remember the antidiuretic hormone, it is being produced in the supraoptic nucleus, right? And in the supraoptic nucleus, it is not only the antidiuretic hormone which is being produced. The another important hormone that is being produced in supraoptic nucleus is the oxytocin. So both of these hormones, that is antidiuretic hormone and oxytocin, both of them, they are produced in the supraoptic nucleus. Then this oxytocin, it is not just only produced in the supraoptic nucleus, it is also produced in the paraventricular nucleus. Now, if you take the hypothalamic nuclei, we have two important nuclei mainly, that is the supraoptic nucleus and as well as the paraventricular nucleus. In the supraoptic nucleus, you have antidiuretic hormone and as well as oxytocin. Whereas in paraventricular nuclei, the hormones that are being produced are the oxytocin, cortisol releasing hormone, thyroid releasing hormone, and as well as the somatostatin. So these are all the hormones which are being produced in the paraventricular nucleus. So now what is the first topic which I'll be discussing now is about diabetes insipidus. Okay. Now in diabetes insipidus, we have a form of central diabetes insipidus, which is nothing but your Wolfram syndrome. Now, can anyone tell me what is the gene that is being mutated in patients with the Wolfram syndrome? Right. So it is exactly a half-minute question. What is the gene that is being mutated in Wolfram syndrome? Excellent. So what exactly is Wolfram syndrome? I'll tell you. The gene that is being mutated in Wolfram syndrome is WFS1. It is WFS1. Now, so what exactly is Wolfram syndrome? The another name for the Wolfram syndrome is, this is also called as the Didmore syndrome. Now, what exactly is your Didmore? DI stands for diabetes insipidus. And what type of diabetes insipidus is that? Central diabetes insipidus. And DM stands for diabetes mellitus. OA stands for the optic atrophy. T stands for deafness. That is what is the composition of the Wolfram syndrome. And the gene that is being mutated in case of the Wolfram syndrome is WFS1. Right? Now, I'll do a quick revision of the entire diabetes insipidus in just 1 minute. Okay. Now, you just follow this particular table, which is very important. So in diabetes insipidus, what we have two forms of diabetes insipidus. One is central diabetes insipidus, where there is decrease in antidiuretic hormone, and nephrogenic diabetes insipidus, where the antidiuretic hormone is being present, but the antidiuretic hormone receptors, they are resistant. That is what is called nephrogenic diabetes insipidus. And the characteristic feature in patients with diabetes insipidus is the development of polyuria. And when we use this word polyuria, what will be the quantity of the urine in a day? That is more than 3 liters per 24 hours. That will be the quantity of the urine output in case of diabetes insipidus. So the clinical features, what they will have is polyuria and as well as the polydipsia. Now, the point is, what are all the various differential diagnoses for polyuria and polydipsia? Please remember, this is very, very important point. Polyuria and polydipsia is also observed in patients with diabetes mellitus, also observed in patients with the Conn syndrome, also observed in patients with the hypokalemia, also observed in patients with the hypercalcemia, also observed in case of the psychogenic polydipsia. Okay, these are all the conditions where you will have polyuria and polydipsia. Now, coming on to the investigations in diabetes insipidus, what is that you will have? The investigations in diabetes insipidus is that the serum osmolality is increased, the urine osmolality is decreased, there will be hypernatremia, and what exactly is the investigation of choice? The investigation of choice is water deprivation test. That is the investigation of choice. And what is the importance of water deprivation test is it will help us to differentiate the central diabetes insipidus from nephrogenic diabetes, and also it helps us to differentiate from psychogenic polydipsia. Okay. Then what exactly is the drug of choice for central diabetes insipidus? That will be desmopressin. And what exactly is the drug of choice for nephrogenic diabetes insipidus? That will be thiazide diuretics. And what exactly is the drug of choice for lithium-induced diabetes insipidus? That is amiloride. So amiloride, it is the drug of choice. And what will be the differential diagnosis for diabetes insipidus? That is psychogenic polydipsia. Now the question comes, how is that you will differentiate psychogenic polydipsia from diabetes insipidus? What did we discuss in case of diabetes insipidus? In diabetes insipidus, the serum osmolality, it is increased, right? The serum osmolality is increased and the urine osmolality is decreased. But in psychogenic polydipsia, what is that you will have is, in psychogenic polydipsia, you will have that there is decrease in serum osmolality and as well as decrease in the urine osmolality. That is what you will observe in case of psychogenic polydipsia. So this is in nutshell about diabetes insipidus. Then now I'll just give you 3 important clinical scenarios. Please try to crack that 3 important clinical scenarios. I have 3 patients. All these 3 patients, they presented with polyuria and as well as polydipsia. Then what I have done in them is, I have tested the urine osmolality and as well as serum osmolality. So what I have got is in one patient, I got the serum osmolality increased, urine osmolality decreased. And second patient, both urine and serum osmolality decreased. And in third patient, the serum osmolality is normal or increased, urine osmolality is increased. Now, can anyone tell me what is this first group of patient? Can anyone tell me what is this first patient suffering with? Right, very good. Excellent, Pratyusha. So the first patient is suffering with diabetes insipidus. And what about the second patient? And what about the second patient? So polyuria, polydipsia with both decrease in urine and serum osmolality. That is suggestive of, very good, Subhashri, that is psychogenic polydipsia. And what about the third patient? What about the third patient? Polyuria, polydipsia, serum osmolality is normal, but urine osmolality is increased. So the third patient is suffering with, very good, Subhashri, that is diabetes mellitus. Because in diabetes mellitus, why the urine osmolality is increased? Because there is glucosuria. Because of the glucosuria, the urine osmolality increases. That is the reason why you will have the urine osmolality being increased, right? So that was about diabetes insipidus. And you see this quick question. Name the channel on which the antidiuretic hormone acts. Aquaporin 1, 2, 3, 4. Quickly. Name the channel on which the antidiuretic hormone acts. Yes. Yes, yes. So that will be the aquaporin 2 channel, right? That will be the aquaporin 2 channel, right? Now, then followed by that, you see the next important question. Which important receptors do the drugs prescribed to control bleeding esophageal varices in a 55-year-old male with chronic liver disease primarily act on? Right. So this is an important question. Let me see who will crack this question. Which receptors do the drug prescribed in the bleeding esophageal varices? Right. Now, this is very, very important. Let me tell you. Now, what exactly is the drug of choice for the bleeding esophageal varices is terlipressin. So terlipressin, it is the drug of choice for the bleeding esophageal varices, right? Now, where will this terlipressin act? This particular terlipressin, this will act on the V1 receptors. Now, what is another name for the V1 receptors? What is another name for V1 receptors? 9999. Right? Yes. So the another name for the V1 receptors, yes, that will be, yes, very good. That will be R1B. That will be R1B. Whereas R2 receptors are V2 receptors and R1A receptors are V3 receptors. Okay. Now, on this particular, yes, yes. So on this particular V2 receptors, what will act on this V2 receptors? Your desmopressin will act. Okay. Whereas terlipressin will act on the R1B. So everyone is aware of V1, V2, V3 receptors. But what is that you should know is the another name for V1 is R1B. The another name for V2 is R2. The another name for V3 receptor is R1A, right? So that was the discussion related to your diabetes insipidus. We are done with the diabetes insipidus. Now we'll move on to the next question. Or next condition, next endocrine condition. What would be the expected laboratory finding in a 65-year-old female with confusion, right-sided weakness, worsening hyponatremia, and history of sertraline use for the depression and a past stroke? Yes, anyone? What would be the expected laboratory finding in a 65-year-old female with confusion, right-sided weakness, worsening hyponatremia, and a history of sertraline use? Yes, very good, Vasif. So this is a clinical scenario of the SIADH. This is a clinical scenario of the SIADH. Now you should know that in patients with the SIADH, that is syndrome of inappropriate antidiuretic hormone, what is that you will have? You will have the hyponatremia, right? You will have decrease in serum osmolality, and you have increase in urine osmolality. So now tell me which particular option is coinciding with this. And what will happen to the aldosterone levels? There will be increase in aldosterone levels. Okay, I'm sorry. In patients with SIADH, you will have decrease in aldosterone levels. I'm very sorry. There will be decrease in aldosterone levels. So now, which particular option is coinciding with this, right? So if I'm not wrong, the option A. So there is decrease in serum osmolality, increase in urine sodium, and as well as decrease in the serum aldosterone levels. Now, what is that which is making you to think of the SIADH in this question? Let me tell you. So in patients with the SIADH, there is hyponatremia. And because of hyponatremia, the individual will be in a state of altered sensorium. Then why is that you are having this right-sided weakness and past stroke? Please remember, one of the very important etiology that is causing SIADH is the cerebrovascular accidents will cause the syndrome of inappropriate antidiuretic hormone. And the antidepressants, that is sertraline, is also the drug which will be causing syndrome of inappropriate antidiuretic hormone. So that is the etiology in this clinical scenario is CVA and as well as the sertraline use. Now, what is that I'll be doing is I'll be doing the quick revision of this entire topic, that is syndrome of inappropriate antidiuretic hormone. So in case of the SIADH, what are the compensatory mechanisms that will be activated? Compensatory mechanisms that will be activated is there will be inhibition of RAS, right? And there will be inhibition of the sympathetic outflow, right? And the next important is there will be increase in the release of the atrial natriuretic peptide. Now, if you take the etiology, one of the very important malignancy that will be causing SIADH is the oat cell carcinoma of the lung, which is nothing but small cell carcinoma of the lung. Then, what are the drugs that will be causing your SIADH? In the question, like we had one antidepressant, that is your sertraline. So, tricyclic antidepressants, selective serotonin reuptake inhibitors. Then we have the vincristine. Then we have the desmopressin, right? Desmopressin. These are all the drugs that will be causing SIADH. And neurological conditions which will be causing SIADH will be the cerebrovascular accidents, right? And another important conditions are the Guillain-Barré syndrome, amyotrophic lateral sclerosis will also cause the SIADH. Now, what will be the clinical features? The clinical features in SIADH are mainly because of the hyponatremia, right? So hyponatremia, they will have altered sensorium, confusion, and as well as seizures. Now, in the investigations, just now, as I have said you, there will be increase in the urine osmolality. There will be decrease in the serum osmolality. There will be decrease in the serum sodium, right? There will be increase in the urine sodium. Then what exactly is the investigation of choice? See, for diabetes insipidus, you have water deprivation test, whereas here you have water loading test, right? Then what is the first line treatment that you will have in patients with SIADH? So the very important first line treatment is the water restriction, right? So how much of the water that you need to give in patients with SIADH is you need to give 800 ml per day, not more than that. Then what exactly is the drug of choice in patients with SIADH? That includes Vaptans. Okay, so we have tolvaptan and as well as the conivaptan. So that will be the treatment for the SIADH, right? So that was about the topic related to diabetes insipidus and SIADH. Now we'll move on to the discussion of the next important topic, right? Next. I hope everyone is following properly. There is no problem as such. Okay, and as I have said you that the PDF of these particular sessions, it has been shared on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, and it is also shared on Dr. Bhanu Prakash Telegram channel as well. Okay, right. So which of the following statement about the prolactin hormone is not true? Yes, its secretion peaks during the REM sleep. It is the only hormone which is under the inhibitory control of the hypothalamus. Its stimulation is stimulated by TRH and vasoactive intestinal polypeptide, and it promotes lactogenesis, galactopoiesis, and increases the sexual drive. Right. Yes, I'm waiting for your answer. Exactly 1 minute. Right, very good. So we have the correct answer from Pratyusha. Right, so the answer is, please remember, prolactin will not increase the sexual drive. Prolactin is the one which will decrease the testosterone levels. prolactin will decrease the sexual drive. Okay. And this will cause decreased libido. This will cause decreased libido. And their levels, they are elevated during the REM sleep. And it is the only hormone under the inhibitory control of the hypothalamus by your dopamine. Hypothalamus will produce dopamine that will inhibit the prolactin secretion. And its stimulation is stimulated by thyroid releasing hormone and as well as the vasoactive intestinal polypeptide. That is it. So A, B, C are true statement. Then what are the other physiological causes for hyperprolactinemia if the question is asked? One is your REM sleep. The other one is stress, that is during surgery or trauma. Then pregnancy, then lactation, and then nipple stimulation. Okay. These are all the physiological causes for hyperprolactinemia. But if the question is asked, what are the drugs that will be causing increase in the prolactin levels? So it should be dopamine receptor blockers or dopamine antagonists. Examples are like metoclopramide, then phenothiazine, then risperidone, then alpha-methyl-dopa. These are the drugs which will increase the prolactin levels, right? So the answer here is D. That is an incorrect statement. Now, yes, you see the next question. We have a 35-year-old female presented with 1-year history of menstrual irregularity and galactorrhea. She also had on and off headache. Her examination revealed bitemporal superior quadrant anopia. Her fundus examination showed primary optic atrophy. Which of the following is the most likely diagnosis in this case? Yes. Yeah, so there is bitemporal superior quadrant anopia. Very good. So now the answer in this question is the pituitary macroadenoma. It is not craniopharyngioma, right? Why? I will tell you. Because very close differential diagnosis for your pituitary macroadenoma, it is actually craniopharyngioma. Because craniopharyngioma is also the tumor which will increase the prolactin level by compressing the pituitary stalk. But how is that you will be able to differentiate craniopharyngioma from prolactinoma? So craniopharyngioma, the age of presentation, if you observe, bimodal age of presentation. So it is observed in children and it is observed in elderly individuals, right? And you need to understand that in craniopharyngioma, you will not have bitemporal superior quadrant anopia. In case of craniopharyngioma, you will have bitemporal inferior quadrant anopia is what you will observe in case of craniopharyngioma. That is how you will be able to differentiate pituitary macroadenoma from the craniopharyngioma, right? So now what is that we will do? We'll do a quick discussion of the prolactinoma or pituitary macroadenoma. So I will just take exactly 1 minute. Okay. So prolactinoma, it is a tumor. It is the most common secretory tumor of the pituitary, right? It is the most common secretory tumor of the pituitary. Meanwhile, can anyone tell me if the question is asked, what is the most common tumor of the pituitary? What will be the answer? Most common secretory tumor is prolactinoma. But if the question is asked, like, what is the most common tumor of the pituitary? What will be the answer? Any one of you? Most common tumor of the pituitary, please remember, it is, right? It should be, yeah, very good, Sajan. It is non-functional adenoma or non-secretory adenoma, right? Non-functional adenoma or non-secretory adenoma. So that will be the correct answer if the question is asked, what is the most common pituitary tumor? So microadenoma in case of prolactinoma means where the size of the tumor is less than 10 mm, right? Whereas macroadenoma is that where the size of the tumor is more than 10 mm. The difference is what? In case of microadenoma, you will have only endocrine manifestations. Whereas in macroadenoma, you have endocrine and as well as the mass effect features. And what are the physiological causes for hyperprolactinemia? Just now I have discussed. And pathological causes will be prolactinoma, craniopharyngioma, and the drugs. What are all the various drugs also I have discussed. And what will be the clinical features in females? In the clinical features in females is that they will have galactorrhea, they will have amenorrhea, and they will have infertility. So this will be the manifestations. Whereas in males, they will have decreased libido, and even them, they will have the infertility. What will be the features of the mass effect? The features of the mass effect is that they will have bitemporal hemianopia, right? Then what is the investigation of choice? Investigation of choice will be serum prolactin levels and how much it should be, more than 200 micrograms. Then what is the first line treatment for prolactinoma? The first line treatment for prolactinoma will be the dopamine agonist, and the dopamine agonist that we give in pregnancy is that we give bromocriptine, whereas in non-pregnant individuals, right, what we give is cabergoline. Okay, so that will be dopamine agonist. So either it is microadenoma or macroadenoma, whatever it is, dopamine agonist is the first line treatment. And if the individual is refractory to this dopamine agonist, then we do the surgical resection of the tumor. Okay, now you see this question. Following procedure is useful in the treatment of pituitary microadenoma, macroadenoma, both, and then hypothalamic tumors. First of all, can anyone tell me what exactly is this procedure? This procedure is transsphenoidal, right? So it is transsphenoidal pituitary adenectomy. So this transsphenoidal pituitary adenectomy, it is useful for both, that is microadenoma and as well as the macroadenoma as well, right? So that was about the story related to prolactinoma. Then we'll move on to the next important clinical scenario and as well as next important endocrine disorder. So we have a 34-year-old woman presents to the endocrine clinic with a history of postpartum hemorrhage during childbirth 6 months ago. Since then, she has been experiencing fatigue, weight gain, decreased appetite, difficulty in breastfeeding. On examination, she appears pale and her blood pressure is slightly low. Which of the following is not true about the hormone that is likely to be affected first in the disease? The gene for this hormone are located on chromosome 17. Its production is maximum during REM sleep. It increases in conditions like exercise, surgery, trauma. It increases the insulin increase or resistance. Okay. Now, can anyone tell me, right, what is this particular hormone that I am talking about? First of all, what is this clinical scenario? This clinical scenario, it is suggestive of hypopituitarism. Okay. Now, in hypopituitarism, what is the first hormone that will be reduced? In hypopituitarism, the first hormone that will be reduced is, yes, please answer this, not thyroxine. The first hormone that will be reduced is the growth hormone. So growth hormone is the one which is reduced first. And please remember, the growth hormone, what is the question asked? Which of the following is not true about the hormone that is likely to be affected first in this case? So growth hormone, it is not increased in the REM sleep. The growth hormone levels are increased in the NREM sleep. That is what you need to understand. And the gene for the synthesis of the growth hormone, it is present on the chromosome 17. And the growth hormone levels increases in exercise, surgery, and as well as trauma. And growth hormone is the one which will increase the insulin resistance. Okay. Now, so let us discuss about the growth hormone related abnormalities now. Okay. Now, what are the growth hormone related abnormalities? That will be acromegaly. So acromegaly is that which is characterized by increase in growth hormone production in adults. Right? Increase in growth hormone production in adults. That is what is called acromegaly. Right? And same again, like as you have pituitary adenoma, here it is somatotroph type of cells will be there in case of acromegaly. And in macroadenoma, the size of the tumor is more than 10 mm. Microadenoma, the size of the tumor is less than 10 mm. Okay. But which is more common in case of acromegaly is macroadenoma is more common than microadenoma. Exactly reverse is there in prolactinoma. In prolactinoma, microadenoma is more common than compared to that of the macroadenoma, right? Now, if you take the skeletal manifestations, what will be observed in skeletal manifestations? So you have like the broad fingers, right? And hand size is increased. And you have, right, the large foot and the shoe size is increased. And if you take the head circumference is increased. There will be frontal bossing. And if you observe the nose, there will be broad nose. And if you observe the jaw, you will notice that there is prognathism and there will be widely spaced teeth. That will be the skeletal manifestations. Then what will be the soft tissue manifestations? The soft tissue manifestations that you will have is multiple soft tissue manifestations. One of the very important soft tissue manifestation is increase in the skin thickness. There is hypertrophy and hyperplasia of the sweat glands causing profuse sweating. There is enlargement of the tongue and there can be development of the obstructive sleep apnea. Right? And what will be the CNS manifestations? CNS manifestations is that if there is macroadenoma, there will be raised intracranial pressure causing headache. And there will be also compression of the optic chiasma causing visual abnormalities. Okay. And what will be the abnormal metabolism? So there will be increase in gluconeogenesis. The individual will develop diabetes mellitus. And there will be also dyslipidemia. There are three endocrine disorders where you will have dyslipidemia. One is hypothyroidism, you will have dyslipidemia. Acromegaly, you will have dyslipidemia. Diabetes mellitus, you will have dyslipidemia. And one more, that is Cushing syndrome. Okay, four endocrine disorders where you will have dyslipidemias, right? Then, what is the first line investigation in patients with acromegaly? You need to estimate the levels of the IGF-1, right? IGF-1 levels are elevated. That will be the first line investigation. Then what is the investigation of choice in the acromegaly? You need to give the oral glucose tolerance test, right? What is this oral glucose tolerance test is? It is the failure of the growth hormone secretion. Failure of growth hormone secretion in spite of glucose load. That is what is the investigation of choice. Then what is the first line treatment in patients with acromegaly is surgical resection is what you need to do. Then what exactly is the drug of choice? Drug of choice in case of the acromegaly is you need to give somatostatin analogs, that is octreotide should be given, right? Or we have lanreotide or the pesireotide should be given. Okay, that will be the drug of choice in patients with the acromegaly, and this will be the appearance of a patient with the acromegaly, where you have the presence of the broad face, and you have the frontal bossing, and you have the broad nose, right? And you have the prognathism. That is what you will observe in case of the acromegaly. And even if you observe the hands, so you have this is the normal hand, right? And this is the acromegaly hand. And this is the normal foot, right? And this is the foot in case of acromegaly, where you can observe that broadness. And when you do the imaging of the digits, what is that you will do observe in the imaging of the digits is isolated spade-shaped phalanx. That is because of increase in the growth hormone levels. And not only that, when you do the X-ray of the foot in the lateral view, you will notice that there is increase in the foot pad thickness. What is the normal foot pad thickness? Is 13 to 21 mm, and here it is increased more than 21 mm, right? So that was about the story related to the
అయింది సార్.
Chalo, okay. All right. So please let me know in the comment section, am I audible to all of you? Yes, am I audible and visible to all of you? Just give me a quick thumbs up or just quick response. All right, great. Okay, great. So I was reading some of the previous comments, right? So as such, this is called as rapid revision. Okay, so in the rapid revision, so definitely we will go rapidly only. And about the annotation, the file with annotation, I'll be sending you. Yes, I'm writing the short forms in order to ensure that to cover all the topics. Okay, and I'll be sending you a file with fill in the blanks of that tables also. I have another PPT file where I have the file which is being completely filled with the type. Okay, so I'll be sending you that as well immediately after the session, so don't worry. So this is called as rapid revision. Definitely it will be fast only, right? Because I need to cover many topics as well. So right, coming on to, yes, where are we? We are in this question. So 50-year-old female presents to the emergency department with severe right upper quadrant pain radiating to the back. She also complains of nausea and vomiting. On examination, tenderness is noted in the right upper abdomen and Murphy's sign is positive. Laboratory investigation revealed elevated liver enzymes and bilirubin. The patient has history of long-term treatment with a drug for a disease which manifests with enlarged hands, feet, and facial features, as well as joint pain and sweating. Which of the following are not the additional uses of the given drug apart from the treatment of the above disease? Okay, if anyone can crack this, I'll be very happy. Yeah, Bhuwana, so how will you diagnose acromegaly? First line investigation is IGF-1 levels that are elevated, and the investigation of choice is oral glucose tolerance test, where there will be failure of growth hormone suppression in spite of glucose load, right? Yes, excellent. So the answer here is the management of hyperthyroidism. So what exactly is this clinical scenario is? The clinical scenario is the acromegaly. And in acromegaly, what is the drug that we use is we use the somatostatin analogs. What is that? Octreotide. And this particular octreotide, now why is this Murphy sign being positive? The octreotide, it will cause cholestasis, right? So this will cause cholestasis. And this will result in cholecystitis, right? So this will result in cholecystitis. And because of this cholecystitis, you have the Murphy sign being positive. And this somatostatin analog, that is octreotide, it is used in the treatment of the portal hypertension. It is also used in the treatment of the insulinoma. It is also used in the treatment of the carcinoid syndrome, but it is not used in the management of the hyperthyroidism. That is what exactly is the question. So the question is, which of the following is not the additional use of the given drug apart from the treatment of the above disease? Okay, right. Now, one more question. What is the mechanism of action of the drug used to prevent the recurrence of the tumor in a 45-year-old male with acromegaly and facial changes? Growth hormone receptor antagonist, somatostatin analog, dopamine agonist, adrenal steroid. Yes, I will send you the PDF with annotation also immediately after the class is over. Don't worry about that. Right, excellent. So, very good. The answer is the growth hormone receptor antagonist. So what is the drug that you will give in order to prevent the recurrence of acromegaly is we give pegvisomant. Okay. So pegvisomant, what is the mechanism of action? That is, it is a growth hormone receptor antagonist. That is what is the mechanism of action of the pegvisomant. So that finishes the discussion related to your acromegaly. Acromegaly is done, right? Then coming on to the next question. Pituitary apoplexy is associated with which of the following manifestations? Hypertension, shock, unconsciousness, fatigue. So what do you think is the correct answer here? Great. So pituitary apoplexy, yes. So pituitary apoplexy, it is associated with the development of shock, right? What exactly is the pituitary apoplexy? Pituitary apoplexy is that where there is hemorrhage in the pre-existing pituitary adenoma. That is what is called as the pituitary apoplexy. And in patients with pituitary apoplexy, they will not have hypertension, they will have the hypotension. And unconsciousness and as well as fatigue, they are non-specific manifestations in patients with the pituitary apoplexy. And this pituitary apoplexy will result in what? This will result in what is called as the hypopituitarism. Now, the detailed discussion of the hypopituitarism is what we will do now first. So, if you take this hypopituitarism, what is the first hormone that will be reduced in hypopituitarism? The first hormone that will be reduced in hypopituitarism will be the growth hormone. Then what is the most common cause for hypopituitarism? The most common cause for hypopituitarism will be the pituitary adenoma, right? Pituitary adenoma. Then what is pituitary apoplexy? Just now I was discussing where there is hemorrhage in a pre-existing pituitary adenoma. Then what are the inflammatory causes that will be causing hypopituitarism? That includes the sarcoidosis, right? That includes the tuberculosis. Then what will be the clinical features? So in hypopituitarism, the clinical features, it completely depends upon which hormone is being deficient. So the first hormone that will be deficient is the growth hormone, and followed by that, you will have decrease in the LH and as well as the FSH. Okay. And followed by that, you have decrease in the subsequent hormones. So there will be decrease in the ACTH, there will be decrease in the TSH. So whichever the hormone is being deficient, and accordingly you will have the manifestations. Then how is that you will manifest? I mean, how is that you will check the levels of the ACTH? The levels of the ACTH, it is tested by what is called as metirapone test. Right? It is being tested by what is called metirapone test. Okay. Now, what exactly is this metirapone test? Metirapone test is the one which will increase the ACTH levels. Basically, metirapone will decrease the corticosteroid levels. When corticosteroid levels are reduced, what should happen to the ACTH? It should increase, right? So whenever you give metirapone, ACTH should increase. But in spite of giving metirapone, if the ACTH does not increase, that is suggestive that there is some pathology within the pituitary. Then how is that you will test the growth hormone levels, right? We do what is called arginine infusion test. Why? Because whenever you give arginine, the growth hormone levels should be elevated. But in spite of giving arginine, if the growth hormone does not increase, that means that there is some pathology within the pituitary. So why is that you cannot test direct levels of the ACTH and as well as growth hormone? Why? Because the ACTH production and growth hormone production, it occurs in a pulsatile manner. That is the reason why you cannot estimate the ACTH and growth hormone directly within the blood. Whereas the levels of TSH, the levels of LH, the levels of FSH, this can be estimated within the blood. Then, then what exactly is the drug of choice? So drug of choice means like what is the first drug that need to be supplemented? Can anyone answer this? The first drug that need to be supplemented is steroid. And what is that particular steroid that we give is dexamethasone is what you need to give. Okay, dexamethasone is the drug which is having maximum steroid activity. So that is the reason why dexamethasone has to be given. And that was about your hypopituitarism discussion, right? Then we will move on to the next important clinical scenario. What is the most appropriate measure to prevent the complication like elevated blood glucose, round face, central obesity, poor wound healing in a 32-year-old male with severe asthma prescribing long-term oral steroid? What is the most appropriate measure to prevent the complications like elevated blood glucose, round face, central obesity, and poor wound healing in a 32-year-old male with the severe asthma prescribing long-term oral steroid? Right, very good, Bhuvana Raghu. So what exactly is this clinical picture suggestive of? This clinical picture, this is suggestive of Cushing syndrome. Okay, then how is that you can prevent the development of the Cushing's? Is if the patient is developing this round face, hyperglycemia, central obesity, what is that you need to do? You need to gradually taper the corticosteroid dose and then completely stop the drug, right? And completely stop the drug. That is what you need to do, right? Then followed by that, I'll show you one more important question related to the Cushing's. That is, you see this question. Which of the following changes are most likely to occur to the ACTH and cortisol respectively after the administration of high-dose dexamethasone in an old woman who comes to the office due to difficulty in climbing stairs, dyspnea on exertion with serum cortisol level is at upper limit of normal that is not suppressed following administration of low-dose dexamethasone. She also has the elevated serum ACTH levels with chest X-ray showing right lower lobe lung mass, right? So please answer what would be the clinical scenario first of all, right? Then what would be the best answer? Yes, very good. So what exactly is this? This is also the clinical diagnosis suggestive of the Cushing's, right? Then what exactly is the cause of the Cushing's here? The cause of the Cushing's here is the oat cell carcinoma of the lung. Okay, because the patient is having a mass within the chest X-ray, right? So in oat cell carcinoma, which is an ectopic ACTH, whenever you do or whenever you give high dose dexamethasone, will the ACTH gets reduced? No. Will the cortisol gets reduced? No. So the answer here is no change, no change. Okay. So what is the most common cause for the Cushing's? The most common cause for Cushing's is the iatrogenic steroid supplementation. Most common cause for Cushing's will be iatrogenic steroid supplementation. So quickly, let me discuss about the Cushing syndrome, right? Just 1 minute, okay? What exactly is the difference between the Cushing syndrome and Cushing's disease? Cushing's disease is that if the development of Cushing's, if it is due to pituitary adenoma, then we call it as the Cushing's disease. Then what is the most common cause of Cushing syndrome? That is the iatrogenic steroid supplementation. Then what is the most common non-iatrogenic and what is the most common ACTH dependent cause for Cushing's? That will be the pituitary adenoma. That will be pituitary adenoma. Then what is the most common cause for ACTH independent type of Cushing's? That will be adrenal adenoma. Then what is the earliest clinical feature of the Cushing's? That will be weight gain, right? What will be the dermatological manifestations in Cushing's? That will be development of the purple striae and as well as the hyperpigmented skin. But please remember, the hyperpigmented skin will be observed only in case of ACTH dependent type of Cushing's. Then what will be the abnormal metabolisms? Abnormal metabolisms will be, there will be hyperglycemia due to increase in hepatic gluconeogenesis. And these patients, they will have proximal muscle myopathy. Why is that they have proximal muscle myopathy? Is due to increased proteolysis. And there will be also lipolysis in these individuals. Because of lipolysis, there will be release of free fatty acids and there will be redistribution of the free fatty acids causing round face, buffalo hump, and central obesity. What will be the cardiovascular system manifestations? That is the hypertension. What will be the neurological manifestations? These patients will develop psychosis or the emotional instability. What is the first line investigation? The first line investigation will be the 24-hour urinary cortisol levels will be elevated, right? Then, if the 24-hour urinary cortisol levels are elevated, then immediately what is the next important step that you need to do? You need to check the ACTH levels. If you find that the ACTH levels are suppressed, that means it is ACTH independent type of Cushing's, which is nothing but adrenal adenoma and adrenal carcinoma, in which you need to do CT or the MRI of the abdomen. If the ACTH levels are elevated, then what is the investigation of choice that need to be done first? The investigation of choice that need to be done first, if the ACTH levels are elevated, is you need to do MRI of the pituitary. Why? In order to look for pituitary adenoma. Because the most common cause for ACTH dependent type of Cushing's is pituitary adenoma, you need to do MRI of the pituitary. Now the point is, if the MRI of the pituitary is normal, then you need to do high dose dexamethasone suppression test. See, MRI of the pituitary can be normal even though there is pituitary adenoma in almost 10% of patients, because the pituitary adenoma, if the size is small, then the MRI cannot detect that pituitary adenoma. So the MRI can turn to be normal. Then you need to do high dose dexamethasone suppression test. With high dose dexamethasone, if there is suppression of the ACTH, that is suggestive of pituitary adenoma. If with high dose dexamethasone, if the ACTH levels are elevated, then you need to suspect ectopic ACTH. What is the most common cause for ectopic ACTH? That will be the oat cell carcinoma of the lung. That will be the most common cause for the ectopic ACTH. All right. Then coming on to the treatment in patients with the Cushing's. Okay. So what will be right? What will be the first line treatment? The first line treatment that you will be doing in these patients will be surgical resection of the tumor, right? Surgical resection of the tumor. Then what exactly is the drug of choice? Those individuals where surgery is contraindicated, then you need to give the drug. And the drug that you need to give is the ketoconazole. Why is that we are giving ketoconazole? Because ketoconazole is an adrenal enzyme inhibitor. It will inhibit the steroid synthesis. That is the reason why we give this particular ketoconazole. Okay. Then we have many other drugs. We have ketoconazole. Then we have metirapone, right? These are all the drugs that can be given, but the drug of choice is considered to be the ketoconazole. Now, can anyone tell me, when you do a bilateral adrenal resection in patients with the Cushing's, you need to give supplemental steroid in the form of the hydrocortisone, right? Because when you do bilateral adrenal gland resection, the steroid levels will be reduced. So whenever you do bilateral adrenal resection, immediately you need to give steroid. Now, if the steroid is not given, can anyone tell me what is the syndrome associated with that? If steroid is not given after doing bilateral adrenal resection, what will be the syndrome that can develop? Very good. So these patients will develop what is called as Nelson syndrome, where there will be hyperpigmented skin, right? So this is about the Cushing syndrome. Now, let me just show you the images in the Cushing syndrome. So this is what is nothing but your purple striae, right? And this will be the hyperpigmented skin. Now, hyperpigmentation is observed in which type of Cushing's? It is only in case of the ACTH dependent type of Cushing's, you have the presence of the hyperpigmented skin, right? So that was about your Cushing's. Yeah, please answer this question. All of the following are true about the condition shown except. Yes, all of the following are true about the condition shown except. Right, so great. So yes, the answer is hyperkalemia will not be there. So these patients with the Cushing's, they have hypokalemic metabolic alkalosis. Right, they have hypokalemic metabolic alkalosis, and this hypokalemic metabolic alkalosis, it is mainly observed in case of the ectopic ACTH produced steroids. And what will be the most common cause for ectopic ACTH, as just now I have discussed? That is oat cell carcinoma. Apart from oat cell carcinoma, what are the other causes for ectopic ACTH? That includes medullary carcinoma of thyroid, that includes bronchial carcinoid, that includes even your pheochromocytoma. Okay. So this is suggestive of Cushing's because you have the presence of the buffalo hump and you have the presence of the purple stripe, right? Then we will move on to the next important clinical scenario, right? Which physiological process is primarily associated with cortisol and may be impaired in a 38-year-old female presenting with chronic fatigue, increased susceptibility to infections, and low cortisol levels? Yes, primarily associated with cortisol. Right. Very good. Yeah. So the answer here is the cortisol. I'm sorry. Just 1 minute. Okay, so this particular cortisol, what is it associated with? It is associated with modulation of the body stress response, and as well as the immune function, right? So it is a stress hormone and it is an immunosuppressive hormone. Okay. Then coming on to the next important, we are done with the Cushing's ho gaya. Coming to the next question, which result from salt loading test is most consistent with suspected diagnosis in a female with persistent refractory hypertension, hypokalemia, metabolic alkalosis, elevated plasma aldosterone concentration, and suppressed plasma renin activity? Yes. What do you think is the correct answer here? Yeah, it is Conn syndrome, Pratyusha. But what exactly is the answer here? Yes? No. Right. Very good, Bhuvana Raghu. So the answer is B here. Okay. Right. We are talking about what we are discussing about the hyperaldosteronism. The clinical scenario is about Conn's, which is nothing but the hyperaldosteronism is what is nothing but your Conn's. Okay. And in patients with hyperaldosteronism, what exactly is the investigation of choice? It is the salt loading test. That is oral salt solution test. In spite of giving oral salt solution, there is significant increase in the plasma aldosterone. That is the investigation of choice, and that is a feature of these patients with the Conn's. And in patients with the Conn's, you have decrease in the renin levels. You will have decrease in the renin levels. Okay. Yeah. Right. Yes. Yeah. Great. Very good, Bhuvana Raghu. Nice. So in patients with the Conn syndrome, what is that you will have? You will have transient hypernatremia, you will have hypokalemia, and you will have decrease in the H plus ion levels. And this decrease in H plus ion levels, that will be metabolic alkalosis. Okay. And the same picture, that is hypokalemic metabolic alkalosis, is observed in case of ectopic ACTH coming from the Cushing's. Now, we'll do the quick revision of the Conn syndrome. Okay. So what exactly is the Conn's? The Conn's is adrenal adenoma, right? Adrenal adenoma. You see the difference here, very important. If the question is asked, what is the most common cause of primary hyperaldosteronism? The most common cause for primary hyperaldosteronism will be bilateral adrenal hyperplasia. Whereas if the question is asked, what is the most common cause for Conn syndrome? Then the answer should be adrenal adenoma. Okay. So only we use the word Conn's only for adrenal adenoma. Then what will be the clinical features in Conn's? The clinical features in Conn's will be, there will be polyuria and there will be polydipsia. And these patients, they will have very severe form of the muscle weakness. Why there will be muscle weakness? That is because of the hypokalemia. And because of hypokalemia, they will also have ventricular tachycardia and ventricular fibrillation. And why they will have this polyuria? Usually in case of Conn's, whenever there is hyperaldosteronism, there should be increased water reabsorption at the level of distal tubules. But because of aldosterone escape phenomena, these patients will have the polyuria. Then what exactly is the first line or the screening test in Conn's? The first line or screening test in Conn's is the aldosterone-renin ratio. Aldosterone-renin ratio will be increased. Why? Because aldosterone levels will be high and renin levels will be low. Then what is the investigation of choice? The investigation of choice will be the oral salt solution test. Okay. Then what is the first line treatment in patients with the Conn's? The first line treatment in patients with the Conn's will be the surgical resection is what you need to do, right? But if there is presence of bilateral adrenal tumors, you should not do surgical resection, because when there is bilateral adrenal tumors, when you do surgical resection, there can be decrease in steroids also. So whenever there is bilateral adrenal tumors, what is that you need to do then? You need to give the aldosterone antagonist. Example of the aldosterone antagonist is spironolactone. And the differential diagnosis for the Conn syndrome is Liddle syndrome. It is a genetic disorder which is autosomal dominant type of inheritance. What exactly is the problem in the Liddles? There is gain of function of the ENaC. there is gain of function of ENaC. Okay, and these patients, they will have the hypertension. And very important is, what exactly is the drug of choice in Liddle's? The drug of choice in Liddle's, you need to give the ENaC blocker, that is amiloride should be given. Now, apart from amiloride, what we give is triamterene. Another example of the amiloride is, another alternative to your amiloride is triamterene should be given. So this is the quick revision of the Conn syndrome, right? Now, we will have one more question. Okay, the clinical scenario. Which statement is true regarding the drug of choice for the treatment of the disease in a 35-year-old female with low blood pressure, hyperpigmentation, hyponatremia, hyperkalemia, low plasma cortisol, elevated plasma ACTH levels? Yes. So what exactly is this clinical scenario? No, I did not get the correct answer. So this particular clinical scenario, it is suggestive of the Addisons, right? Yeah, Sajjan has answered it correctly. This clinical scenario is suggestive of the Addisons. Now in Addisons, what exactly is the drug of choice? Drug of choice is hydrocortisone, right? And this particular hydrocortisone, it has equal mineralocorticoid and as well as the glucocorticoid activity, right? So the answer is C here. It is not B, it is not A, right? So now let me do a quick discussion related to the Addisons. So yeah, 1 or 2 minutes, we'll finish the Addisons, right? What is the most common cause of Addisons in India? That is tuberculosis. What is the most common cause of Addisons in West? That is autoimmune adrenalitis, right? And the viruses that will be causing the Addisons will be your HIV and as well as the cytomegalovirus. Then what is the most common fungal infection that will be causing Addisons? That will be histoplasmosis, right? Then we have a condition called adenomyoleukodystrophy. What exactly is this? It is an X-linked disorder. It is a disorder which is more commonly observed in males rather than females. And here what exactly happens? It is a disorder where there is accumulation of long-chain free fatty acids within the adrenal gland. It is a disorder where there is accumulation of long-chain free fatty acids within the adrenal gland causing adrenal insufficiency. What is Waterhouse-Friderichsen syndrome? Waterhouse-Friderichsen syndrome is that where there is abrupt deficiency of adrenal cortical hormones. Okay. Then what is the etiology for the Waterhouse-Friderichsen syndrome? That includes Neisseria meningitidis, which is nothing but meningococcus, which is usually observed in children. What exactly will be the problem here? There will be development of the adrenal hemorrhage, and these patients, they present with abdominal pain because of the adrenal hemorrhage, right? The clinical features that you will have due to this, because in Addison's, there is steroid deficiency, aldosterone deficiency, and weak sex hormone deficiency. The clinical features due to steroid deficiency is that they will have hypoglycemia, right? Why? Because the hepatic gluconeogenesis does not occur. There will be weight loss because metabolism does not occur. And there will be fatigue because there is no ATP synthesis. And due to aldosterone deficiency, there is hyponatremia. And because of the hyponatremia, these patients, they will have the altered sensorium. Right? They'll have altered sensorium. Okay. And these patients, they will be craving for salt. Why? Because the food which is rich in sodium is salt. So they'll have salt craving. And there will be hyperkalemia and there will be increase in H plus ion, and that will result in metabolic acidosis. And due to weak sex hormone deficiency, the features are very commonly observed in females. Now, what will be the features that you will observe in females is that in females, these patients, there will be loss of secondary sexual characteristic features. What will be that loss of secondary sexual characteristic features? That is axillary and pubic hair will be lost. And in primary adrenocortical insufficiency, there will be hyperpigmented skin. Because in primary adrenocortical insufficiency, which is called Addison's, there is increase in the MSH. Whereas in secondary adrenocortical insufficiency, where the pathology is anterior pituitary, in these patients, they will have hypopigmented skin. And this hypopigmented skin This is what is called as the alabaster skin. And why is that due to? This is due to decrease in MSH because of decrease in ACTH levels, right? And then what is the important difference between primary and secondary? In primary adrenocortical insufficiency, everything will be reduced. The steroid will be reduced, the aldosterone levels will be reduced, and as well as the weak sex hormone levels also will be reduced. Okay, and the ACTH levels will be increased. MSH levels will be increased. Whereas in secondary, everything will be same, but aldosterone levels will remain normal, steroid levels will be reduced, weak sex hormone levels will be reduced, ACTH levels will be reduced, then MSH levels also will be reduced. Then what exactly is the investigation of choice in Addison's? That will be post-syntopin test, which is also called as the ACTH stimulation test. What exactly is the drug of choice in primary? That is hydrocortisone, because it is having the dual activity. In primary, we want both aldosterone and as well as the corticosteroid activity. Whereas drug of choice in secondary, that will be dexamethasone. What is the drug of choice in Waterhouse-Friderichsen syndrome? We give intravenous hydrocortisone. And the antibiotic that we give in these patients with Waterhouse hydrocortisone. Okay. And in Waterhouse-Friderichsen syndrome, the antibiotic that we give in these patients will be ceftriaxone is what we give in these patients. So that finishes about your Addison's, the quick revision of the entire Addison's. Okay. Now, yeah. So you can observe the great personality who had this particular, the Addison's is John F. Kennedy. He was the former president of United States of America. So he had this Addison's. And that is the reason why you can observe the pigmentation. It is the hyperpigmented skin, right? And yeah, so this will be the alabaster skin, right? And you have many differential diagnoses for this alabaster skin or the hypoalbinism. Even that is also a differential diagnosis, right? So we are done with the discussion related to the Addison's. Let me just discuss one clinical scenario related to the Addison's. 35-year-old female presents to the clinic with complaints of fatigue, weakness, weight loss over the past few months. She also reports experiencing episodes of dizziness and low blood pressure. On physical examination, her skin appears hyperpigmented, particularly on the knuckles, elbows, and knees. Lab investigation revealed hyponatremia, hyperkalemia, elevated plasma ACTH levels. Where are the receptors for the involved hormone in this disease? Yeah, Rakshit, the ACTH levels cannot be estimated. Whatever you have said is absolutely right. But whenever you check the ACTH levels during that pulsatile release, why ACTH we are not able to check? Because of pulsatile release. So during that pulsatile release also, if you estimate that ACTH levels or you give metirapone test, you will find that the ACTH levels, they will be reduced in secondary and they will be increased in case of primary. So pulsatile secretion is what I am talking about. Yeah. So now so what is this discussion about? Yes, anyone? So the patient is having the episodes, I mean, weight loss is there, dizziness is there, low blood pressure, hyperpigmentation. So what is all this suggestive of? So all this is again suggestive of the Addison's, right? Okay. So in Addison's, what is the hormone that is being deficient? The hormone that is being deficient, that is your steroids. So if you take the steroids, where will be the nucleus of the steroids? The nucleus for the steroids, it will be both the nuclear and as well as the intracytoplasmic. Okay. So for steroids, for mineralocorticoids, and as well as the weak sex hormones. So for all these hormones, the receptors are present on both nucleus and as well as the cytoplasm, right? Now, that was about the Addison's. Now we'll move on to the next important endocrine disorder. The most appropriate initial investigation for a male who presents with sudden onset severe headache, palpitations, a profuse sweating with a family history is Mm. All right. So, yeah, right. Right. So we are very sorry for the technical issue, right? I do definitely understand it creates a little bit irritation if the flow of the session is being stopped in between, right? But the technical issues we cannot help. Okay, it will not be there in our hand. So we'll try to ensure that we'll continue with the remaining part of the class now. Okay. Right. So yes, please answer this question. The most appropriate initial investigation for a male who presents with. So, what is the clinical scenario suggestive of? No, yaar, I did not get the correct answer from any one of you. Yeah. So, the clinical scenario, it is suggestive of the pheochromocytoma. Yes. So, the clinical scenario, it is suggestive of the pheochromocytoma. So, in pheochromocytoma, yeah, yes. In pheochromocytoma, what will be the initial investigation and what will be the confirmatory test? Both are there. So, the initial investigation that, yes, many of you are answering. So the initial investigation will be 24-hour urinary levels of metabolites of catecholamines and the plasma metanephrine levels. This will be the confirmatory test, right? This will be the confirmatory test. Okay, right. And yeah, please don't get confused with the DOTA-TATE scan. Yes, Pratyusha, I'll come to the DOTA-TATE scan. What exactly is that? I'll discuss about the DOTA-TATE scan. Okay, right. And yeah, you see this next question. VMA is elevated in which of the following conditions? Primary micronodular adrenal hyperplasia, Conn syndrome, neuroblastoma, tuberous sclerosis. Yeah, initial investigation will be 24-hour urinary levels of VMA, right? Yeah, please answer this question. I'll discuss the entire pheochromocytoma. I'll discuss in detail. Great. So the condition where the VMA levels are elevated will be not only pheochromocytoma. Apart from pheochromocytoma, the levels are also elevated in patients with the neuroblastoma. The levels, they're also elevated in ganglioblastoma, ganglioneuroma, and as well as the severe anxiety. Right? So these are all the conditions where the VMA levels are elevated. So now what is that we'll do now? We'll do the quick discussion of the pheochromocytoma. So pheochromocytoma, what is the most predominant hormone that will be produced in pheochromocytoma? That is the norepinephrine. And what is the most common site for the extraadrenal pheochromocytoma? Extraadrenal pheochromocytomas, they are called as the paraganglioma. They are called as paraganglioma. And what is the most common site for paragangliomas are? It is abdominal para-aortic area. Right? Abdominal para-aortic area. And what is that abdominal para-aortic area? That will be the organ of Zucker-Candle. Right? Then what will be the most common symptom and as well as sign? Most common symptom will be headache and most common sign will be hypertension. Then apart from that, the other cardiovascular system manifestations in these patients will be palpitations. That is because of increase in the heart rate. And these patients, they will also have angina. Why? Because there is increased demand and decreased supply. Okay. And carbohydrate metabolism, if you observe, there will be increase in glycogenolysis. Thereby, there will be increase in glucose levels in patients with the pheochromocytoma. And what will happen to the hematocrit? It will be increased. What will happen to the calcium levels? That also will be increased. Why? Because the pheochromocytoma will produce like parathormone related protein, which will increase the calcium levels. And the postural reflexes, they are lost. And thereby these patients, they will have the postural hypotension. So why is that they have postural hypotension? That is due to blunting of the postural reflexes. What will be the first line investigation? Just now we were discussing 24-hour urinary levels of catecholamines, metabolites of catecholamines, that is VMA. And investigation of choice will be plasma metanephrine levels. And this plasma metanephrine levels, that should be elevated more than 4 times. That should be elevated more than 4 times. Okay, that will be the investigation of the choice. Right now, if you observe the discussion, like what is the imaging of the choice? The imaging of the choice will be gallium 68 dotatate PET scan. Dotatate PET scan. What is the treatment of choice? That will be surgical resection of the tumor. What is the drug of choice? Before doing surgery, you have to ensure that the blood pressure is reduced to less than 160 by 90. So you need to give an alpha blocker. What is that alpha blocker that we need to give? That is phenoxybenzamine should be given. So that finishes the discussion related to your pheochromocytoma. We are done. And when you do a biopsy in patients with the pheochromocytoma, what is that characteristic appearance called as? The characteristic appearance, it is called as nest of Zellballen appearance. Actually, we don't do FNAC. FNAC, it is like completely contraindicated in pheochromocytoma. But after the death of the patient, if you just do the histological analysis of the tumor or after surgical resection, if you do the histological analysis, you will have this characteristic description called as nest of Zellballen appearance. Okay, so that was about your pheochromocytoma. We are done with the adrenal gland disorders. Then we'll discuss the parathyroid disorders, right? Then coming to this question first. We have a 45-year-old man with a history of primary hyperparathyroidism come to your clinic for follow-up visit. He was diagnosed 3 years ago after routine blood tests revealed an elevation in the calcium levels. He has no complaints. Review of the system is negative. His physical examination is unremarkable. His family history is negative for similar problems. His calcium levels are 12.5. DEXA scan shows T-score of -2. What do you think is the most appropriate treatment regimen that you will be doing in this particular patient? Yeah, Bhuwana, what do you want to do? You want to give bisphosphonate. All right. Any other answer? Surgeon, you also want to do, you also want to give bisphosphonate. Pill also want to give bisphosphonate. Okay. But what is the correct answer here? See, the correct answer is refer the patient to the experienced surgeon and get the parathyroid surgery being done. Okay. Why? Because what exactly is this case? Primary hyperparathyroidism. What is the most common cause for primary hyperparathyroidism? The most common cause for primary hyperparathyroidism is solitary parathyroid adenoma. That is the most common cause for the primary hyperparathyroidism. And in solitary parathyroid adenoma, what is the treatment of choice? The treatment of choice will be surgical resection of the tumor. And another important indication for surgical resection in this clinical scenario is if the calcium level is elevated more than 1 gram, the normal value, then you need to do surgical resection in primary hyperparathyroidism. How much is the normal calcium levels? That is 9 to 11 milligrams per deciliter. How much is the calcium in this patient? 12.5. So he is an ideal candidate for doing the surgical resection. Okay. So the answer here is refer to the experienced surgeon for parathyroid surgery. So what is the discussion that we will be doing now? So we will be doing the quick discussion on the hyperparathyroidism. So if the question is asked, most common cause for primary hyperparathyroidism, just now as I was discussing, it is solitary parathyroid adenoma. Okay. After this solitary parathyroid adenoma, the other causes will be parathyroid carcinoma and parathyroid hyperplasia. Then what are the causes for secondary causes for hyperparathyroidism? That includes the chronic renal failure. That includes vitamin D deficiency. That includes the malabsorption syndrome. Right? That includes the malabsorption syndrome. Okay. Right? And what are the causes? Why there is secondary hyperparathyroidism? Remember, any condition whichever is causing hypocalcemia or wherever there is hypocalcemia, in all these conditions you have hypocalcemia that will be causing your secondary hyperparathyroidism. Now, whenever there is hypercalcemia, what will be the clinical manifestation? See, 9 to 11 milligrams per deciliter is the normal calcium levels, right? And if the calcium levels are elevated more than 11, then you will have the clinical manifestations like renal stone or renal calculi will be there. And because of the renal calculi, these patients will have the renal colic or there will be presence of the abdominal pain. Right, then these patients will have the abdominal pain, right? And not only that, these patients will also have the constipation, okay? And these patients will also have the development of the nephrogenic diabetes insipidus. And because of nephrogenic diabetes insipidus, these patients, they will have polyuria and as well as the polydipsia. They'll have polyuria and as well as polydipsia. These are all the manifestations of hypercalcemia. And not only that, these patients will also develop secondary Parkinsonism. These patients will also develop secondary Parkinsonism. Okay. Why? Because the calcium will cross the blood-brain barrier and it will accumulate in the basal ganglia, causing secondary Parkinsonism. Then what will be the bony abnormalities? There will be osteoporosis because of the excessive bone resorption. What is the cause of death in patients with hyperparathyroidism is whenever there is hypercalcemia, these patients will have the systolic arrest and finally death. What is the investigations here? Please remember, you need to check the parathormone levels that will be elevated, calcium levels that will be elevated, phosphorus levels will be reduced, and there will be increase in the alkaline phosphatase levels. And DEXA scan will show you that bone mineral density will be decreased. Bone mineral density will be decreased. Okay. Then coming to the imaging localization. So how is that you will be able to localize that solitary parathyroid adenoma is technetium 99M sesame B scan. That is the investigation which will localize the solitary parathyroid adenoma. So what is the treatment of choice in case of primary hyperparathyroidism? You need to do surgical resection. That is a treatment of choice. Then what is the first line treatment for the hypercalcemia? First line treatment for hypercalcemia is you need to give IV fluids plus furosemide should be given that will flush out the calcium. Then what exactly is the drug of choice for primary hyperparathyroidism? You need to give bisphosphonate. Why? Because bisphosphonates are the one which will inhibit the bone resorption. So that is the reason why we give bisphosphonates. But all this is what? This is a treatment for primary hyperparathyroidism. And in secondary hyperparathyroidism, you need to treat whatever is the underlying cause. And if you see the bony abnormalities in hyperparathyroidism, you have the development of the osteitis fibrosa cystica, right? And you have the development of what is called as the codfish spine. And this codfish spine is due to excessive resorption by increased parathormone levels. And these patients, they will also have what is called as rugged jersey spine. Why is that they have this rugged jersey spine? That is because of increased resorption from the bone, right? And they will also, you will also notice that there is pinhead stippling. That is also because of the bone resorption. And absence of lamina dura. What is lamina dura? Lamina dura, it is the mineralized portion of the mandible, right? Lamina dura, it is the mineralized portion of the mandible. Okay, right? So that mineralized portion of the mandible is being lost, right? Then yeah, renal osteodystrophy. Yes, Pratyusha. Renal osteodystrophy, you get that in case of chronic renal failure. In chronic renal failure, you will have the renal osteodystrophy. Okay, right. Then, yeah, you take this lamina dura. So this is the mineralized portion of the mandible. And that mineralized portion of the mandible, that will be lost in patients with the primary hyperparathyroidism. Okay, so that was about the story related to the hyperparathyroidism, right? Then you take next important clinical scenario and let me see how many of you can answer this. We have a 66-year-old woman presents to a walk-in clinic with muscle spasm. She complains that for the past 2 days, she has had muscle spasms in her hand, arm, and legs. She has a medical history of cervical Hodgkin's lymphoma, which was treated with radiation. She does not take any medications or vitamins. On physical examination, the Trocheus sign is positive. Her calcium levels are 6.8 and the albumin is normal. On the basis of the patient's history, what is the most likely diagnosis and what should be the treatment? Yes, I'm waiting for your answer. Right. So this particular patient is having hypoparathyroidism that is secondary to radiation therapy because the patient is having cervical Hodgkin's lymphoma for which the individual has undergone the radiation. So the patient has developed hypoparathyroidism secondary to the radiation therapy. So what is that you need to start? You need to start calcium and as well as the calcitriol. So what is that we will be discussing now? We'll be discussing quickly related to the hypoparathyroidism. What is the important etiology that will be causing hypoparathyroidism? See, acute hypoparathyroidism, you will observe in case of the surgical resection of the thyroid. Because whenever you are doing surgical resection of the thyroid for the large goiter, there is a high scope that parathyroid glands are also taken off, resulting in acute hypoparathyroidism. Okay. And what are the other etiologies that will be causing hypoparathyroidism? The other etiologies that will be causing hypoparathyroidism will be hypomagnesemia, right? And the radiation therapy, just now we have discussed one of the very important clinical scenario. Okay. And we have a genetic disorder that will be causing hypoparathyroidism, that is Dye-George syndrome. So Dye-George syndrome, please remember this particular mnemonic, that is catch-22. That is catch-22. So in catch-22, you have this hypocalcemia. That hypocalcemia is because of hypoparathyroidism and abnormality is on chromosome number 22. Right? Abnormality is on chromosome number 22. And what will be the clinical features due to hypocalcemia? They will have tetany. And along with tetany, the other features will be, there will be perioral paresthesia, right? And there will be periungual paresthesia. Now, how is that you will be able to make out the latent tetany? Latent tetany can be made out by two important signs that is called as the Trocheus sign and the other one is the Chostek sign. I show you both of these signs, okay? right? Trocher's sign and as well as Chostek's sign. What is the cause of death in these patients with hypoparathyroidism causing hypocalcemia is laryngospasm. Then how will you investigate these patients? Parathormone levels will be reduced, calcium levels will be reduced, there will be increase in the phosphorus levels, right? And the QT interval will be prolonged because of the hypocalcemia, right? And the alkaline phosphatase levels, that will remain normal. What is the treatment? If it is acute hypoparathyroidism, in this case, you need to give intravenous calcium gluconate. If it is chronic hypoparathyroidism, in chronic hypoparathyroidism, you need to give oral calcium gluconate, right? You need to give oral calcium gluconate in case of chronic hypoparathyroidism. And not only that, you also need to give vitamin D supplementation, which is nothing but calcitriol. What is pseudo-hypoparathyroidism? Here, parathormone, it is present in adequate quantities, right? Parathormone is present in adequate quantities, but parathormone receptors, they are being resistant in these patients. And why is that the parathormone receptors being resistant? That is due to gene mutation. And the gene that is being mutated is GNAS1 gene is being mutated, right? And in patients with pseudo-hypoparathyroidism, please remember, there will be hypocalcemia. Why? Because parathormone is not able to act on parathormone receptors. So how is that you will treat that hypocalcemia is you need to give the oral calcium gluconate supplementation. You need to give oral calcium gluconate supplementation. Okay, right. Then, yeah, this is what is nothing but your Trocher's sign. What is Trocher's sign? You need to increase the blood pressure within the cuff, and you need to maintain this between systolic blood pressure and diastolic blood pressure. Hold on for 1 to 3 minutes. Then what is that you will observe? You will observe that there will be development of the carpal spasm. That is called Trocher's sign seen in latent tetany. Then what is Chostek's sign? Chostek's sign is that you tap the facial nerve over the angle of mandible. When you tap the facial nerve over the angle of mandible, you will notice that there is spasm. You will notice that there is spasm of the facial muscles on the affected side. Okay, that is what is called as the Trocher's sign. And sorry, that is what is called Chostek's sign, right? Then we also have another terminology is called Trocher's sign. This is nothing but observed in case of the carcinoma of the stomach. In carcinoma of the stomach, you have what is called as the Trocher's lymph node or the Virchow's lymph node. Why does this occur? That is due to metastasis from carcinoma of the stomach to the supraclavicular area. Then we have one more syndrome called Trocher's syndrome that you observe in case of the carcinoma of the pancreas, and that is due to migratory thrombophlebitis. That is due to migratory thrombophlebitis. Okay, and in patients with the hypocalcemia, you will also have the bony abnormalities. What will be that bony abnormalities? Genovalgum, genovarum. Genovalgum is like knock knees. Okay, so you take a gum, right? You take the gum and you fix both the knees. That will become knock knees. Genovarum, you take a rum bottle and place between both the knees. That becomes the bolex. So these are the bony abnormalities that you will have because of the hypocalcemia, right? So this is about the discussion related to the parathyroid, that is hypo and as well as hyperparathyroidism. Done? Now, we'll move on to the discussion related to the thyroid gland. Yes, so we'll do some quick questions on the thyroid. What mechanism is primarily responsible for hormonal changes observed in 35-year-old male with weight gain, fatigue, constipation, cold intolerance, dry skin, coarse hair, and reduced levels of TSH, T4, and T3? Right. So the correct answer is from Dr. Vasif. So this particular patient is having hypothyroidism. But what type of hypothyroidism is this? This is a secondary hypothyroidism because TSH, T3, T4, everything is reduced. So reduced synthesis of TSH by the anterior pituitary. So when TSH is reduced, obviously T3 and as well as T4 also will be reduced, right? So it is secondary hypothyroidism, right? So the answer is D, that is a fourth option. Okay. Whereas in primary hypothyroidism, what is the clinical picture that you will have? In primary hypothyroidism, T3, T4 will be reduced, TSH will be increased. Okay. So this is primary picture. Now you just see the next question. What process is most likely directly inhibited by methimazole treatment in a 22-year-old women with palpitations, weight loss, insomnia, diffuse non-tender thyroid enlargement, low TSH, and elevated thyroxine? Yeah. So this is what actually, this is hyperthyroidism. So in hyperthyroidism, what is the drug of choice? That is methimazole. What is the mechanism of action of methimazole? Mechanism of action of the methimazole is, it's a thionamide, right? It's a thyroid peroxidase inhibitor. It's a thyroid peroxidase inhibitor. Now, if you take all the drugs that we give in patients with hyperthyroidism, we give these thionamides. Examples are methimazole and propylthiouracil. What is their mechanism of action? They inhibit thyroid peroxidase enzyme, which one? Methimazole. And propylthiouracil will not only inhibit the thyroid peroxidase enzyme, it will also inhibit the peripheral conversion of T4 to T3. Whereas you take iodides, potassium iodide and as well as Lugol's iodine. They are called thyroid constipating drugs, and they will block the release of thyroid hormone released from the thyroid gland. That is what is your iodide solutions. Okay. Then you take radioiodine, that is iodine 131. It will emit the beta rays and it will destroy the thyroid gland completely. Then we have cyanates, that is potassium cyanate or thiocyanate. What they will do? They inhibit the iodide transport into the thyroid gland. So basically what these drugs will do? They inhibit sodium iodide symporter, which is present on the thyroid follicular cell. But these drugs are outdated. We are not using this particular thiocyanates these days. Okay. Now, coming to the etiology causing hyper and as well as hypothyroidism. So if you take the discussion, what is the most common cause for the hyperthyroidism? That will be Graves. Right? What is the most common cause for hypothyroidism in India? Right? Most common cause of hypothyroidism in India. That will be Hashimoto's. And globally, it is iodine deficiency. Clinical features, right? None to say, like what will be the features that these patients will be having? Very important, they will have palpitations. They will be having hypertension, right? They will be having heat intolerance. They will be having weight loss. They will be having profuse sweating, right? And they will be having increased appetite, right? They will be having diarrhea. And they will be also having increase in the respiratory rate, right? There will be also increase in the respiratory rate, okay? Tachypnea will be there. And there will be anxiety and as well as tremors. Whereas in hypothyroidism, what they will have? They will have bradycardia. They will have diastolic hypertension. They will have cold intolerance. They will have weight gain. Okay. They will have dry skin. And these patients, they will have constipation. And these patients, they will have decrease in the respiratory rate causing type 2 respiratory failure. They'll have excessive sleep. And they will have this hung-up reflex. Hung-up reflex is what? Where there is delayed relaxation of deep tendon reflexes. Okay. Now, what is Jod-based dose phenomena? Jod-based dose phenomena is iodine-induced hyperthyroidism is what is called Jod-based dose phenomena. What is Wolff-Chaikoff effect? That is iodine-induced Hypothyroidism, that is what is called Wolff-Chaikoff effect, and that is due to transient inhibition of the organification. So this will be the differences between the Graves and as well as the Hashimoto's. I'll show you one clinical scenario of thyroid. Yeah. What mechanism is most likely responsible for clinical presentation of a 45-year-old female with fatigue, weight gain, cold intolerance, thyroid enlargement, elevated TSH, decreased T4, as indicated by the FNAC? As indicated by the FNAC. Now, Pratyusha, what is the clinical diagnosis of this patient? What is the clinical diagnosis of this patient? Yeah, very good, Shravanti Kodali. So the answer is A. So this clinical diagnosis, it is suggestive of hypothyroidism, right? So if it is a hypothyroidism, what it should be? Your Hashimoto's, most common, autoimmune destruction of the thyroid follicular cell. Excess production of thyroglobulin by thyroid follicular cell, this will result in hyperthyroidism. And activation of the hypopituitary thyroid axis, even this will cause hyperthyroidism, right? And decreased iodide intake, yes, this will be causing the hypothyroidism. Okay, but what is the most common cause in India? That will be Hashimoto's, right? And not only that, you take in case of the biopsy, you can see the infiltration of the lymphocytes. You have the infiltration of the lymphocytes. Okay, and you have this presence of the pink colloid, and that we call it as the Hurdle cells. Okay, that we call it as Hurdle cells. Okay, so this is your Hashimoto's thyroiditis. Then coming to the workup in case of hyper and as well as hypothyroidism, one of the very important part of the workup is radioactive iodine uptake. Radioactive iodine uptake, what is that we use is the iodine 132 or iodine 123 is what we will use for the radioactive iodine uptake studies. And you should know the conditions where there is high radioactive iodine uptake, and you should know the conditions where there is low radioactive iodine uptake. High radioactive iodine uptake, right? Increased radioactive uptake is in case of Graves. Where is that you will have decreased radioactive iodine uptake? Decreased radioactive iodine uptake, you have that in case of subacute thyroiditis. You have that in case of subacute thyroiditis. What is the treatment in case of hyperthyroidism? Drug of choice will be what? Methimazole. But in pregnancy, what is the drug we give? In pregnancy, in the first trimester, the drug of choice will be what? That will be propylthiouracil. Whereas in second and as well as third trimester, again we give methimazole. Why? Because we don't give methimazole in the first trimester because of teratogenicity. And teratogenicity associated with methimazole is aplasia cutis. That is what is observed with methimazole. And propylthiouracil, it is not associated with teratogenicity. So once the organogenesis is over, then we will shift back to methimazole. Why is that we give methimazole in second and third trimester? Why? Because methimazole has long half-life than compared to propylthiouracil. And not only that, propylthiouracil, it will cause very severe hepatic fibrosis. That is the reason why we don't give propylthiouracil in second and third trimester, right? Then you take the treatment in hypothyroidism. In hypothyroidism, the drug of choice will be levothyroxine. We give T4, right? We give T4. And this particular T4, when is that you should give? You need to give early morning fasting state. Why is that we are giving early morning fasting state? Why? Because if you give thyroxine after the food can impair the absorption of the thyroxine. That is the reason why we don't give thyroxine after the food, right? And what is the dosage of the thyroxine? That is 1.6 microgram per kg body weight. Okay, so that is about the levothyroxine, what we give in patients with the hypothyroidism, right? Now, yes. What is the endocrine disorder associated with the following presentation? Acromegaly, Cushing syndrome, Addison's, and then hypothyroidism. Yes. Yes, right. So this is hypothyroidism. Why? Because What is this suggestive of? This is suggestive of the pericardial effusion. This is suggestive of the pericardial effusion, where you have the description of the heart as water bottle appearance or money bag appearance. Where do you have pericardial effusion? That is in hypothyroidism. So the answer is the hypothyroidism here. Next, let me just ask you one more question. What is the mechanism by which the beta blocker impact thyroid hormone synthesis and release in a 32-year-old male with hyperthyroidism experiencing tachycardia, tremors, anxiety, as well as the possible atrial fibrillation? Inhibition of the iodide uptake by the thyroid gland, decreased conversion of T4 to T3 in the peripheral tissues, suppression of the TSH secretion from the anterior pituitary, blocking the stimulatory effects of the thyroid stimulating immunoglobulin on the thyroid gland. Yes, any one of you? Right, excellent, Bhuvan Raghu. So how is that these beta blockers will be acting? Please remember, beta blockers, they are the one which will inhibit the peripheral conversion. What are all the various reasons why we give beta blockers in hyperthyroidism? Beta blockers, they reduce the tremors in patients with hyperthyroidism. Beta blockers, they reduce the anxiety in patients with the hyperthyroidism. That is the reason why we give beta blockers, right? And beta blockers, they also inhibit the peripheral conversion of T4 to T3, and thereby it is useful in the treatment of the hyperthyroidism. And you need to know what are all the various drugs which will inhibit the peripheral conversion. So T4 to T3, it is by the enzyme 5-DASH deiodinase. What are all the various drugs which will inhibit this enzyme? Please remember, propyl thiouracil will inhibit this enzyme. Beta blockers will inhibit this enzyme, right? And hydrocortisone, even that also will inhibit this enzyme. 5-DASH deiodinase enzyme will be inhibited. Okay, so the answer here is B, that is the second option, right? Now, we'll do some quick discussion related to the thyroid tumors. Okay, so what is the most likely diagnosis for a 45-year-old male with painless, palpable, firm, fixed mass in the right lobe of the thyroid gland, elevated serum calcitonin, inconclusive FNAC, and family history of similar thyroid nodules in the sibling? Yes, right. So this should not be a difficult one at all. Why? Because calcitonin, that is being produced by parafollicular cells, right? And what is a tumor which is originating from parafollicular cells? The tumor which is originating from the parafollicular cells will be the medullary carcinoma of the thyroid. Okay, so medullary carcinoma of thyroid, if you observe, it is the firm, fixed, painless, palpable mass. Okay, if you are observing that there is painless, palpable mass, that too like firm in consistency, that is very much suggestive of malignancy, right? And this medullary carcinoma of thyroid, it is associated with MEN2A. It is also associated with MEN2B, right? MEN2A and as well as MEN2B. So the answer here is medullary carcinoma of thyroid. Now, this makes me to come to the discussion of the MEN syndromes. Right? What is another name for MEN1? Any one of you? The another name for MEN1, this is also called as Werner syndrome, right? And you should not get confused with the Werners. Okay, what is Werners? Werners is progeria, right? Werners is progeria, which is nothing but premature aging. Whereas MEN2A, right? MEN2A, this is called as the Sippel syndrome. Right? And MEN2B, which is also called MEN3, this is called Wagenman-Frobois syndrome, right? And you don't have any other name for MEN4, okay? Then you should know the chromosomal abnormality. MEN1, you have the abnormality on the chromosome 11, whereas the MEN2A and MEN2B, you have abnormality on chromosome 10. MEN4, you have abnormality on chromosome 12. What is the gene? In MEN1, the gene itself is called as MEN1 gene. Okay, so that is the tumor suppressor gene. Whereas in MEN2A and MEN2B, the gene that is being abnormal is that is RET proto-oncogene, which is present on chromosome number 10. And MEN4, the gene that is being mutated is CDKN1B, right? CDKN1B. What are the tumors in MEN1? Please remember 3Ps, right? What are these 3Ps? These 3Ps will be the pituitary tumor, parathyroid tumor, then the pancreatic tumor, right? But out of all these, which is the most common P? The most common will be parathyroid tumor, that is solitary tumor or solitary parathyroid adenoma. Then you take MEN2A. In MEN2A, please remember this mnemonic, that is TAP. What is this particular TAP? That is thyroid abnormality. That is medullary carcinoma of thyroid. A stands for adrenal pheochromocytoma, right? And P stands for the parathyroid tumors. Parathyroid tumors. Whereas MEN2B, which is also called MEN3, you have only P and you have only A. P is not there. So just remember. Start just. All right. So yes, am I audible and visible to all of you? I'm very sorry, guys. Very, very sorry for the technical interruption. So what I was just getting the information from the backup team is, right? So this technical error will be there every half an hour, it seems. So what I will do, I will just do only endocrinology now, right? And I will just wind up. right? Tomorrow we have another session, right? So in that particular session, we will have a continuity. So until by tomorrow, right, the backend team is trying to do the appropriate correction, which has to be done. So this particular session, only I will do endocrinology and then I'll wind up. So maybe in another 20 minutes, I'll wind up this particular session. Okay. Right. Yes. Am I audible, right? So just give me a quick thumbs up. Okay. So, all right, great. Now, so you take MEN4. So if you take MEN4, what will be the tumors in case of MEN4? MEN4 is associated with the sex organ tumors. Okay. So what will be that sex organ tumors? In females, there will be cervical tumors, right? Whereas in males, there will be testicular tumors. There will be testicular tumors. And apart from these two, you have two Ps. What is the two Ps? That is the pituitary tumors and as well as the parathyroid tumors. Pituitary and parathyroid tumors. Then coming to the extra endocrine manifestations. The extra endocrine manifestations will be, there will be foregut carcinoids. There will be foregut carcinoids and there will be also angiofibromas. There will be also angiofibroma and there will be also the collagenoma. There will be also collagenoma. This will be the extra endocrine manifestations in MEN1. Whereas in MEN2A, you have amyloidosis, right? Then you also have the Hirschsprungs, which is nothing but the condition which is characterized by congenital absence of the ganglion. Whereas in MEN2B, if you observe, you have the presence of the neuromas, that is gastrointestinal neuromas, right? And there will be also the marfanoid habitus, right? There will be also marfanoid habitus. Okay. So this will be the features in case of MEN syndrome. I'll show you one important image. Please try to identify that. So in which condition do you see this? MEN1, MEN2A, MEN2B, MEN4. Yes. Great. So what exactly is this? Your neuromas, right? So where do you have that? You have that in case of MEN2B, which is also called as the MEN3. Okay. So that finishes the discussion related to your MEN syndromes. Then very important discussion we will start is with diabetes mellitus. Okay. So we have a patient with diabetes mellitus who is having since past years, past 5 years, presenting with vomiting and as well as the abdominal pain. She is non-compliant with medication and appears dehydrated. Investigations revealed a blood sugar value of 500 milligrams per deciliter and the presence of the ketone bodies. What is the next best step in the management? In IV fluids with long-acting insulin, IV fluids only, insulin only, both. Great. So what is this basically? It is a scenario suggestive of diabetic ketoacidosis, right? In diabetic ketoacidosis, we require to give both. We need to give IV fluids, followed by that, you need to give insulin. But this insulin, what we give is, we give that in the form of the infusion. And we give insulin infusion until the ketone bodies turn out to be negative. Until the ketone bodies are turned out to be negative, we keep on giving insulin infusion. Once the ketone bodies are negative, then we give the subcutaneous formulation. Okay. Now, in diabetic ketoacidosis, you are aware of the triad. What is the triad? The blood glucose levels should be more than 250. The ketone bodies should be positive. Then the pH should be the acidic pH. The pH should be acidic pH. Why acidic pH? Because the ketone bodies are acidic in nature. And examples of the ketone bodies are the acetone, right? Then we have the acetoacetic acid. Then we have the beta hydroxybutyrate. We have beta hydroxybutyrate. Okay. Out of all these, the most acidic ketone body will be your beta hydroxybutyrate. And because of this acidosis, what will be the clinical feature? Because of the acidosis, these patients, they will have a very severe form of dyspnea. And they have a characteristic breathing pattern, and that characteristic breathing pattern is what is called as the Kussmaul's respiration. Right? This characteristic breathing pattern is called Kussmaul's respiration. Okay, so that is about your diabetic ketoacidosis. And in diabetic ketoacidosis, what exactly is the treatment of choice? Exactly the treatment of choice is like you need to give IV fluids followed by that insulin infusion. Okay, then you also need to give antibiotics. You also need to monitor the potassium levels, because whenever you are giving insulin infusion, the potassium level decreases. So you need to monitor the potassium level, and you need to give antibiotics. Why? Because infection is the most common precipitating factor for the development of diabetic ketoacidosis. All right. So that is the reason why we give antibiotics. Right now, yes, you see this question. What is the drug of choice for managing recurrent episodes of hypoglycemia in a 45-year-old female with fasting-induced symptoms, elevated insulin, normal body mass index? Yes, great. So can anyone tell me what is the diagnosis of this clinical scenario? What is the diagnosis of this clinical scenario? Very good. So it is insulinoma. Okay. So insulinoma, what is the drug of choice? That is diazoxide. So for long-term management of the hypoglycemia, we need to give the diazoxide. Okay. Whereas glucagon will cause acute increase in glucose levels. Right? In case of acute hypoglycemia, we give glucagon. But for long-term management, what we give is the diazoxide. Okay. So diazoxide is the drug of choice. Now, what we will do, we will have some quick discussion related to the diabetes mellitus. Then we will move on to a few more questions. Okay. So type 1 diabetes mellitus, if you observe, the age of presentation is less than 20 years. And type 2 diabetes mellitus, the age of presentation will be more than 30 years. What is pathogenesis? The pathogenesis in case of type 1, it is the beta cell destruction. Whereas type 2 diabetes mellitus, it is the insulin resistance. Insulin resistance, okay, or receptor resistance. And insulin level will be reduced in case of type 1, or it will be normal or increased in case of type 2. Whereas in type 1, the BMI of the individual will be absolutely normal, whereas in type 2, the individual is obese. And type 1 is a HLA association. And what will be that HLA association? That is HLA DR3 and as well as DR4. Whereas type 2, there is no HLA association. And in type 1, what is the characteristic features? They will have polyuria, polydipsia, and polyphagia. But this polyuria, polydipsia, polyphagia, you don't observe that classically in type 2 diabetes mellitus. In type 2 diabetes mellitus, what will be the clinical manifestation is they will have excessive fatigue. There will be weight loss, right? And these patients, they are more prone for infections. And there is also poor wound healing in case of type 2 diabetes mellitus. And complications, if you observe in case of type 1, diabetic ketoacidosis, that is more common in type 1 rather than type 2. Whereas in type 2, hyperosmolar non-ketotic coma, this is more common in type 2 rather than type 1 diabetes mellitus. And you take microvascular complications that will be observed in both type 1 and type 2. But these microvascular complications and they are common in type 1 than type 2. What are those microvascular complications? That includes diabetic retinopathy. That includes diabetic nephropathy. That includes diabetic neuropathy. Okay. What are the macrovascular complications? That includes coronary artery disease, cerebrovascular accidents, and then the peripheral arterial disease. These are the microvascular complications. So this is like quick discussion of the entire diabetes mellitus, right? Then diagnosis is very, very important, right? So how much should be the normal FBS? It should be less than 100. Normal PPBS, less than 140. HbA1c normal value less than 5.6. Impaired values, if you observe, FBS is around 101 to 125. PPDS, it is 141 to 199. HbA1c, that is 5.7 to 6.4. And you take diabetic range. In diabetic range, the FBS value will be more than or equal to 126. PPDS value will be more than or equal to 200. And HbA1c will be more than or equal to 6.5. What do you mean by the target value? Target value means in already non-diabetic patients, when you have started the treatment, how much should be your FBS value? That should be less than 130. PPDS value, it should be less than 180. HbA1c value, it should be less than 7%. Right? And you will be able to diagnose diabetes mellitus even based on RBS as well. Based on RBS, if the value is more than 200, along with that, if there is clinical features of diabetes mellitus, that will diagnose your diabetes mellitus. And what is the gold standard test for your diabetes mellitus? That is the OGTT, oral glucose tolerance test, right? So that was about the story related to your investigation. And these are very, very important. What are the causes of early morning hyperglycemia in a patient who is on insulin therapy? Right? The causes include fasting hyperglycemia, Donn's phenomena, and the Somogyi effect. Okay? Fasting hyperglycemia, that is because of excess night dose of the insulin. Right? Donn's phenomena, this is due to early morning growth hormone surge. Somogyi effect, that is due to, I'm very sorry. Fasting hyperglycemia is due to decrease in night dose. That means patient is advised actually 20 units, but patient has taken only 10 units. Whereas Somogyi effect, that is due to increased night dose of insulin. That means the patient has been advised 10 units, accidentally the patient has taken 20 units. Okay. And how will you diagnose? Diagnosis is, in fasting hyperglycemia, the patient did not take adequate amount of the insulin. So 3 a.m. blood glucose levels are also, right? 3 a.m. blood glucose levels are high. And 6 a.m. blood glucose levels are also high, right? Because patient did not take adequate amount of insulin. Whereas in Donn phenomena, in Donn's, like 3 a.m. blood glucose levels will be normal. Whereas 6 a.m. blood glucose levels will be elevated, right? Then you take Somogyi. In Somogyi, 3 a.m. blood glucose levels will be reduced. Why? The patient has taken more insulin. Whereas 6 a.m. blood glucose levels will be high. Why? Because of increase in the counter-regulatory hormones. Okay. So fasting hyperglycemia, what is the treatment? You increase the night dose of the insulin. You increase the night dose of the insulin. Donn's phenomena, you ask the individual not to have any carbohydrate snack in the night. And at the same time, you also need to increase the night dose of the insulin. And Somogyi effect, you decrease the night dose of the insulin. Okay. So this is about your Donn's phenomena, Somogyi effect, and as well as the fasting hyperglycemia. Right? Then we have a clinical entity called MODY. That is maturity onset diabetes of young. Maturity onset diabetes of young, what exactly is the pathogenesis? The pathogenesis will be beta cell dysfunction, and because of which the insulin levels are reduced. Okay. And it is a disorder with inheritance. And this is due to, that beta cell dysfunction is due to gene mutation. Right? It is due to gene mutation. It is not beta cell destruction. It is beta cell dysfunction, because of which the insulin levels will be reduced. And these patients, the BMI will be absolutely normal, right? And they will be having a very strong genetic inheritance. Very, very strong genetic inheritance. Minimum 2 generations should be diabetic. That means not only father, even grandfather also should be diabetic. Okay. And if you take the complications in these individuals, they never develop diabetic ketoacidosis. They never develop diabetic ketoacidosis, right? If you take the types, we have MODY 6 types. MODY 1, 2, 3, 4, 5, 6. Out of which MODY 3 is the most common type. And in MODY 3, what is the gene that is being mutated? In MODY 3, the gene that is being mutated is the HNF1 alpha that is being mutated in case of MODY 3, right? What is the treatment that you will be giving in case of MODY? The treatment that you need to give in case of MODY is, drug of choice will be low dose sulfonylurea, right? Low dose sulfonylurea. Okay, this low dose sulfonylurea will stimulate the beta cells, and that will stimulate the release of the insulin. That is about your MODY, maturity onset diabetes of young, which is a variant of diabetes mellitus. Then another important form of diabetes mellitus is LADA. It's a rare form. The another name for this LADA, it is called type 1.5 diabetes mellitus. What is the pathogenesis? Pathogenesis is antibodies are formed against the islet cells. And these antibodies are islet cell antibodies, right? Or the antibodies are the anti-GAD antibodies. These are the antibodies which will be destroying the insulin. And it is latent autoimmune diabetes of adults. So it is observed in elderly individuals. Okay. Now, these antibodies, what they will do? These antibodies, they destroy the insulin. Right? These antibodies, they destroy the insulin. Because they destroy the insulin. So what is the treatment? The treatment is you need to give insulin. Treatment is you need to give insulin because there is insulin deficiency in these patients. So this is about your LADA, latent autoimmune diabetes of adult, right? So that was the story related to diabetes. Now, let me discuss about the pancreatic neuroendocrine tumors. So we were discussing about the insulinoma. Let me just give you the quick presentation of the insulinoma, right? So in case of insulinoma, please remember, it's a pancreatic neuroendocrine tumor. The age of presentation is around 40 to 50 years. Observed in case of men 1. What will be the clinical features? Insulinoma will cause excessive secretion of insulin. That will cause the hypoglycemia. So you'll have all the clinical features of hypoglycemia, psychiatric behavior, emotional outbursts, neuroglycopenic symptoms, everything will be observed, right? And majority of these insulinomas, they are benign tumors. Majority of them, they are benign tumors, okay? And that is if the size is less than 2. If the size is less than 2, benign tumors. But if the size is like 5 to 10, they are malignant tumors. Then how will you diagnose this? You will diagnose this by the endoscopic ultrasound, right? Or by PET-CT. Then how do you treat this insulinoma? These patients will be having recurrent hypoglycemia, for which you need to give frequent small meals. Diazoxide is considered as the drug of choice. And octreotide, that is somatostatin analog, it will inhibit the insulin release from the beta cells. Okay, so that is the reason why we give this particular octreotide, right? So this is about the insulinoma story. Then we will take up the discussion of other pancreatic neuroendocrine tumor. So which physiological process is primarily affected by the hormone responsible for clinical manifestation in a 55-year-old male with a pancreatic mass, skin rash, weight loss, diabetes mellitus, necrolytic migratory erythema, and anemia, right? Can anyone tell me what is the pancreatic neuroendocrine tumor we are discussing about? Very good, Bhuvana. So we are talking about glucagonoma. We are talking about glucagonoma. So what do you think is the correct answer? So glucagon will increase hepatic gluconeogenesis, right? But please tell me, this glucagon, right? This glucagon, will it cause breakdown of the glycogen? Yes. Will it cause the breakdown of the glycogen? Remember, breakdown of the glycogen, it is not caused by glucagon. It is not caused by glucagon. Okay. So the answer here is C. Promotes gluconeogenesis in the liver, synthesizing the glucose from non-carbohydrate precursor. So the answer is C here. Nai, Buona, please remember glucagon will not cause glycogenolysis. And you know what is that which will cause the, I'm sorry. I'm very sorry. Yeah, so yeah, glucagon, it will cause the glycogenolysis. Glucagon will cause the glycogenolysis. It stimulates hepatic glycogenolysis, cause the breakdown of the glycogen and release of the glucagon into the bloodstream. That is absolutely correct. That is absolutely correct. But what is the another important action? Promotes gluconeogenesis in the liver, synthesizing the glucose from the non-carbohydrate moieties. Now you need to opt for the best answer. You need to opt for best answer. So you have two options here. What do you think is the correct answer? A or C? What do you think is the correct answer? Is it A or C? Very good. So the answer is C, then followed by that A. Okay. The primary action of the glucagon is gluconeogenesis, right? Then the secondary action will be glycogenolysis. But the primary action is the gluconeogenesis. Okay. That is the reason why the answer is being C here, right? Now, let me tell you some of the important points about the glucagonoma. So glucagonoma, it's a pancreatic neuroendocrine tumor. And you know where this particular tumor is present? I'll give you options, okay? So it is present in the head of the pancreas. It is present in the neck of the pancreas. It is present in the body of the pancreas. It is present in the tail of the pancreas. Yes, please answer this. Where do you have this glucagonoma? Very good, Bhuwana. So it is present in the tail of the pancreas. So if you want some quick points related to the glucagonoma, please remember it is located in the tail of the pancreas and the tumor is malignant. The size is around 5 to 10 centimeters and the characteristic skin presentation will be necrolytic migratory erythema, right? And the clinical features will be diabetes mellitus, diarrhea, dermatological manifestation, migratory necrolytic erythema, rash progressing to bulla and erosions, and there will be intertriginous or perioral facial sites. There will be rash and there will be weight loss. These are all the features of glucagonoma. And what is the investigation of choice in case of glucagonoma? You need to check for the plasma glucagon levels. That will be more than 1000 picograms per ml. Whenever there is metastasis, you need to do CT or MRI. And how is the prognosis? It is poor prognosis because it is a tumor which is having high malignancy. What is the treatment, right? You need to do debulking surgery. And if there is like metastasis, radio-labeled somatostatin analogs can be given. That was about your glucagonoma. So this glucagonoma was asked as one of the previous year question, very, very important. And by seeing that option as necrolytic migratory erythema, you need to fix the answer as glucagonoma. Okay, next. What is the most likely diagnosis for a 45-year-old female with recurrent diarrhea, abdominal pain, weight loss, cutaneous lesions with necrotic centers, and pancreatic tumors on the CT scan? Necrotic centers. Necrotic centers. Patient having diarrhea. Patient is having abdominal pain. Patient is having weight loss. So here the correct answer is, no, here the correct answer is somatostatinoma. Somatostatinoma, they are the one, these patients, they'll have diarrhea, they'll have the abdominal pain, they will have weight loss, and they will have multiple cutaneous lesions with necrotic center. So there will be central necrosis. Right? There will be central necrosis. Okay. This is suggestive of somatostatinoma, right? Now, whereas you take glucagonoma, it is like completely ruled out because in glucagonoma, the very important feature is what? Necrolytic migratory erythema. It is not like the cutaneous lesions with central necrosis. Necrolytic migratory erythema. You have a skin rash. Okay. So the picture, it is not suggestive of the glucagonoma. right? Insulinoma is completely ruled out because these patients, they'll have recurrent hypoglycemia, okay, right? And they'll not have this diarrhea and weight loss, right? Okay, weight loss can be there, but diarrhea will not be there. And you take VIPoma. VIPoma, yes, they will be having diarrhea. Diarrhea is a very common symptom in patients with the VIPoma. But what are the other features that you'll have in patients with VIPoma? In patients with VIPoma, they will have the hypokalemia, right? And in patients with VIPoma, there will be achlorhydria. There will be achlorhydria. Okay, so your VIPoma is also ruled out. So what is the correct answer here? The correct answer is the somatostatinoma, where there will be diabetes mellitus, right? And there will be diarrhea, and that too a secretory diarrhea will be there. And you have the skin lesions with necrotic center. Skin lesions with necrotic center. Okay, so that was about your somatostatinoma. So this finishes the discussion related to your pancreatic neuroendocrine tumors. And this finishes the entire, okay, I'll discuss some image-based questions. Yeah, what is this instrument and where do we use this instrument? Image-based questions in endocrinology. What is this instrument and where do we use this instrument? So this instrument, it is semi-Sweenstein, right? It is semi-Sweenstein monofilament test. Okay, and where do we use this? Semi-Sweenstein monofilament test, it is used for diagnosis of peripheral neuropathy in patients with diabetes mellitus. Okay, that is the use of this monofilament test or semi-Sweenstein monofilament test. Okay, next. What is this sign? In which clinical condition do you have this? This particular sign is diabetic chiropathy. So diabetic chiropathy is that where these patients, they will have a limited joint mobility. There will be limited joint mobility. So this limited joint mobility will be there whenever there is hyperglycemia. Whenever there is hyperglycemia, they will have limited joint mobility. And whenever the hyperglycemia is corrected, then they will be able to approximate both their hands. Okay, that is what is called diabetic chiropathy. Then, which endocrine disorder you have this and what exactly is this? So this is xanthelasma. This is xanthelasma. And you will have this wherever there is dyslipidemia. What are the conditions where you will have dyslipidemia? Diabetes mellitus. Okay. And you will also have that in patients with the hypothyroidism. And you also have this in patients with the acromegaly. So wherever you have dyslipidemia, you will have this xanthelasmas, right? Then, in which endocrine disorder do you observe this complication? First of all, what exactly is this complication? So this is the ulcer, right? So this is the ulcer and it is a neuropathic ulcer. Okay. And this neuropathic ulcer, it is secondary to diabetic neuropathy. This is secondary to diabetic neuropathy. So how do you treat these patients with the neuropathic ulcer is topical antibiotics will be of no role here. You need to do what is called, you need to make a footwear which is called as the offloading footwear. Right? Offloading footwear. So offloading footwear means what? Like you need to relieve the pressure from the ulcer site. Okay. So this is what is called offloading footwear that we use in case of neuropathic ulcer. Next. What is the name of this dermatological sign and in which endocrine disorder do you observe this? So this is necrobiosis lipoidica diabeticorum. And this necrobiosis lipoidica diabeticorum, you observe this in cases of diabetes mellitus. Okay. And usually it is observed in lower limbs. And this is more common in females rather than males. It is more common in females rather than males. Okay. So this is about the image related to the necrobiosis. This is also the same. Necrobiosis lipoidica diabeticorum. Okay. So yeah. Now, yes. So with this, we are done with the endocrinology. So I will send this PPT with annotations on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? So the technical, in another 5 minutes, again, this session will wind up. Okay. So rather than that, I will just close this particular session because the technical issues are there throughout the session, it seems. So I'll just wind up the session for today. So tomorrow again at 7 p.m. until 12 a.m. we will continue without any obstruction. So by that time, the backend team will try to correct this technical issue, right? I'll wind up this session for now, right? I hope you people have enjoyed the session until now. Tomorrow also, you will be having really amazing session, right? We'll be discussing connective tissue disorders, cardiology, nephrology, and we will take up one more. Pulmonology, we will take up tomorrow. 4 topics we will discuss tomorrow. And the remaining part, we'll be discussing one more day. I will take up and I'll finish that, right? Because rather than having these intermittent breaks in the session, we'll do one session continuously. So with this, I'll wind up this session. Thank you very much and see you tomorrow at 7 p.m.